Hello. Hello, everyone. I hope you can hear me. So, if I'm audible, please give me a thumbs up with if I'm audible or not. We'll be starting this session in 5 minutes. So in previous session we discussed about we discussed about ANS pharmacology and we completed that. So आज we are going to start off with your CVS pharmacology and it's going to take us 2 days to cover almost about 6 to 7 chapters of CVS pharmacology. So today, thank you so much, Mangi. So today, I'll be basically going over 3 chapters, which are super duper important. One is your drugs acting on the renin-angiotensin aldosterone system. That's one. The second that I'm going to talk to you about is nitric oxide and and your vasoactive peptides. That's the second chapter. And the third, we'll be discussing over the cardiac glycosides and the drugs used in heart failure. The remaining chapters, that is your anti-anginal drugs and anti-arrhythmic drugs, and the one more chapter that is there. We'll be discussing those 3 chapters in our next session, that is tomorrow. I hope you have already seen the ANS pharmacology wali cheezein, and you're already guys you have already watched your CVS physiology wali videos. So when we discuss about CVS pharmacology, we'll be going at a much faster speed. And same goes for like drugs acting on the renin-angiotensin aldosterone system as well. We have already discussed that in great detail in your revision videos on your renal physiology. So I would also recommend everyone to watch that as well. And iske baad we can actually go for either your diuretics or your CVS pharmacology. So I'm going to start the session at 10 o'clock sharp, so that people can join in. I've already uploaded this tutorial notes on the Telegram group, so you can check that as well. So you can follow along. I've already done that. Alright guys, so we're going to commence the session today. So as we are discussing the first session on CVS pharmacology, and the first set of drugs that we want to talk about is the drugs acting on the renin-angiotensin aldosterone system. As you guys all know, as we have studied this system in renal physiology in great detail. Okay, so I'll be basically touching over the pharmacological aspects of it. Okay, so just remember guys, that is कि जो हमारा ये जो renin angiotensin aldosterone system है, it basically works on the principles of the JG cells. ठीक है? So we have this juxtagromerular apparatus there in our kidney, which consists of the JG cells, the extraglomerular Lassus cells, okay, that the extraglomerular mesangial cells, and your macula densa. Okay, so macula densa हमारे यहाँ पे they're functioning basically in seeing the amount of sodium that is present in the tubular lumen, and उसके accordingly we adjust कि whether if there is a fall in our blood pressure that is there, मतलब ambulatory blood pressure मान लो if it falls, right? What's going to happen is we're going to see a decreased sodium delivery to the macular densa, and we've already seen that how does that happen, via the release of adenosine and via the decreased production of adenosine, decreased production of ADP, which acts on its specific receptors which are present on the Golgi cells. And we even discussed about the calcium paradox, in increase in calcium usually leads to a decrease in renin secretion. So whatever that thing is, we've already discussed in renal physiology. So just see, अब यहाँ पे हम क्या डिस्कस करेंगे, we have already seen कि renin has already been secreted by the kidneys. ठीक है, just remember one more thing guys, कि जो renin जो है ना, that's also under that is also regulated by a sympathetic nervous system, because as we saw previously, sympathetic nervous system में जो beta 1 receptor है, that's present at the Golgi cells and even at the heart. ठीक है, so sympathetic nervous system can activate the renin, angiotensin, aldosterone system. Okay. So now we have renin. So what does this renin do is, this renin is an aspartyl protease. It's a protease in fact. So it's going to break polypeptides or peptides into the smaller components. So यहाँ पे हमारा जो main thing है, it's going to catalyze the conversion of your angiotensinogen, which is an alpha 2 globulin released by the liver. Okay. It's going to convert it into angiotensin 1. Okay. So that's the first thing, angiotensin 1. Now, this angiotensin 1 is going to go into the liver. Liver में we have the pulmonary endothelium, that is जो pulmonary vasculature का जो endothelium है, वहाँ पे जो भी हमारे vascular epithelial cells हैं, they have this enzyme that is known as your ACE. That's your angiotensin converting enzyme. That's going to convert your angiotensin 1 into angiotensin 2. And हमारे angiotensin 2 is the one which is going to mediate most of its action. And one of those actions was your basically working on the zona glomerulosa of your adrenal glands and basically stimulating production of what? Production of your aldosterone. Okay, so that is why we call it as the renin angiotensin aldosterone system. Okay, so what are the angiotensin ke kya features hai? It releases aldosterone, we know that. And we know aldosterone, how does it mediate? It mediates sodium reabsorption by stimulating sodium potassium ATPase, by stimulating ENaC, that is epithelial sodium channels present at the principal cells, by stimulate, and it also leads to kaliuresis, matlab potassium ka excretion. How? By again stimulating sodium potassium ATPase and the ROMK channels. We've already discussed this. So uske accordingly, it's going to lead to sodium reabsorption or potassium ka excretion. Okay. So one thing is aldosterone के ये हमने function देख लिए. What next? Angiotensin, जो हमारा angiotensin 2 है, that is one of the most powerful vasoconstrictor in a body. I'm just saying one of the most. It's not the most. ठीक है. आज जो हमने MCQ discuss किया था, that is urotensin. Urotensin 11 is a peptide. It's a 11 amino acid peptide released by a body, and that is supposed to be the most powerful vasoconstrictor, I would say. Angiotensin 2 would closely follow urotensin. Okay, so we see that vasoconstriction mediate कर सकता है, and that may lead to contraction of the mesangials, and इसके कारण GFR भी decrease हो सकता है. पर यहाँ पे tricky situation ये है guys, कि जो ये angiotensin 2 के receptors है ना, they're actually present on the efferent arteriole. All right, so they're present on the efferent arteriole. So when they're present on the efferent arteriole, हमने already renal physiology में discuss किया था कि what can happen is whenever the efferent arterial resistance will actually increase, we're going to see an increase in the GFR. But whenever it is going to increase so much, then we might see a decrease in the GFR. Okay, so that is one thing. So accordingly, it can increase the GFR. That's another thing. ADH का release करा सकता है, antidiuretic hormones secreted from the supraoptic nucleus of our hypothalamus. वहाँ से ADH का release अगर होगा, we are going to see free water reabsorption as well. ठीक है? And just remember guys, it can also work on the area prostoma. ठीक है? If it works on the area prostoma, उसके through it mediates increase in ACTH production as well. So these are the roles of your angiotensin 2. So as we saw, this is the JGA apparatus that we talked about. Okay, juxtaglomerular apparatus, and how was it controlling? It was serving as your intermediate and long-term mechanisms of your blood pressure regulation. We've already studied this twice in renal physiology and CVS physiology. Okay, so this is about the baroreceptors, guys. Even when the baroreceptors, जब भी baroreceptors की कम firing होती है, whenever we see a fall in the blood pressure, हम ये कहते हैं कि baroreceptors की there is less firing, and these baroreceptors are present where? They're present either at the carotid sinus or they're present at the aortic arch. So उसके accordingly 9th and 10th nerve के accordingly, what they were doing was whenever the blood pressure increase हो रहा था, baroreceptors were getting stimulated, and ultimately they were depressing the sympathetic nervous system. But यहाँ पे if the blood pressure falls, we're going to see an increase in the sympathetic nervous system. And don't forget guys, because why we're discussing this, because we have beta 1 receptors on the Golgi cells, and uske through we can increase the amount of renin production as well. Okay, so that is how the sympathetic nervous system is linked up with your that is your JG apparatus. So this is we are going to discuss the renin angiotensin system, guys. यहाँ पे हमारे पास दो हैं actually. We have the circulating renin angiotensin system, and then we have the local renin angiotensin system. Let's see. So this is the angiotensinogen which I was telling you about, alpha 2 globulin produced by the liver. Okay, we have renin coming from the Golgi cells. What stimulates renin? Let's see that. A decrease in the blood pressure, a decrease in the blood volume, or sodium loss. That's going to stimulate production of renin from the JG cells. That makes sense. How? Via decreased concentration of sodium chloride in the macula densa. Okay, that was the one which was sensing all of this. Or through activation of your sympathetic nervous system. Why? Which receptors? Beta 1 receptors. So हमारे renin आ गया है. It's going to convert your angiotensinogen into angiotensin 1. This angiotensin 1 is made up of 10 amino acids. I'm going to call it as a decapeptide. Okay. Now the next enzyme that's going to come is angiotensin converting enzyme, which is present on the vascular endothelium, especially the lungs. वहां से angiotensin 1 gets converted to angiotensin 2, which is an octapeptide. मतलब दो amino acids चले गए. Now it's 1 से लेके 8. Guys, this is very important. The nomenclature is very important. So when you write angiotensin 2, we can write it as 1 से 8. Okay. I'm going to discuss what is happening actually is, if I say if this is 1 से लेके 10 amino acids है, तो जो terminal 2 है, they are getting cleaved off. Okay. That is the significance behind it. Alright, so we have angiotensin 2 का production. Now this angiotensin 2 is the one which is mediating your vasoconstriction because it's a very powerful vasoconstrictor. It's leading to sodium and water retention by stimulating aldosterone. It leads to aldosterone secretion, and we know it also stimulates your supraoptic nucleus to produce ADH, so that free water reabsorption भी हो पाए. ये हमने इसके actions पढ़ लिए हैं. So this is angiotensin 2. But this angiotensin 2 often gets converted via an enzyme that is aminopeptidase into angiotensin 3 now. And now it becomes a heptapeptide. मतलब it's a 2 से लेके 8. Do you guys see that, guys? पहले हमने लास्ट के टर्मिनल 2 अमीनो एसिड्स रिमूव किए थे, पर हमने टर्मिनल वाले नहीं रिमूव किए और हमने आगे वाला रिमूव कर दिया. दैट इज व्हाई आई एम मेंशनिंग दिस पेप्टाइड एज 2 से लेके 8. इट्स कंपोज्ड ऑफ 7 अमीनो एसिड्स. सो दिस इज एंजियोटेंसिन 3. एंजियोटेंसिन 3 की पोटेंसी एज कंपेयर टू एंजियोटेंसिन 2 इज वेरी रिड्यूस्ड. ठीक है. सारे एक्शंस जो है ना यहाँ पे गाइस, दैट इज वेसोकंस्ट्रिक्शन और वेदर इट बी एडीएच, एवरीथिंग डिप्रेस्ड है एंजियोटेंसिन 3 में एज कंपेयर टू एंजियोटेंसिन 2. बट जस्ट रिमेंबर, एल्डोस्टेरोन सिक्रीशन की अगर हम बात करें, एंजियोटेंसिन 2 is the same working, it's actually the same as compared to angiotensin 3. तो दोनों के जो potency है इस case of aldosterone secretion में वो exactly same है. ठीक. So now we have angiotensin 3. This angiotensin 3 can further get cleaved off and become angiotensin 4. Again by the enzyme that is aminopeptidase. Now it is an hexapeptide, and just remember guys, proximal से हमने एक और amino acid remove कर दिया. इस करके हम saying this as 3 से लेके 8. So it consists of 6 amino acids. So this is my angiotensin 4. And ultimately these angiotensin 3 and 4 जो भी हमारे products हैं, they're going to get converted into via these angiotensinases into inactive fragments. ठीक है. So this is हमारा circulating renin angiotensin system which is circulating in our body. ये हमारे blood में हो रहा है. The next system, so हमने already ये बात की थी guys कि how all of this is happening. ठीक है. So one more point that I want you to mention is, मान लो if I take an inhibitor that's an ACE inhibitor. ठीक है. So what I do is I block this enzyme that is known as angiotensin converting enzyme. ठीक है. So ACE I blocked. So what am I preventing? I'm preventing the conversion of angiotensin 1 into angiotensin 2. That makes sense. Okay? Just remember guys, this angiotensin 2 actually has a negative feedback on your renin secretion. Okay? So whenever angiotensin 2 levels are going to fall down, this negative feedback is also going to get released. And now I'm going to see an increase in renin. And this increase in renin will what? It will catalyze angiotensinogen into angiotensin 1. I'm also going to see an increase in angiotensin 1 as well. So this is important guys. Okay? So on giving ACE inhibitors, which was inhibiting your ACE enzyme, I'm going to see an increase in renin, I'm going to see an increase in angiotensin 1. That's one point. The second point that I would like to make is कि we have an alternate enzyme as well, guys. हमारे पास एक और enzyme है that is known as ACE2. ठीक है? You might be familiar with this. It was very prevalent when we were studying COVID. So just ACE2, what it does is, whenever angiotensin 1 is building up, we can't convert it into angiotensin 2. So the body takes an alternate route, and ACE2 के through, it converts it into not angiotensin 2, it converts it into angiotensin 1,9 and later on into angiotensin 1,7. Now this is very important guys. This angiotensin 1,7 has exact opposite effects of an angiotensin 2. Matlab, it's going to mediate vasodilation, it is antithrombotic, it is anti-ischemic, it is anti-proliferative. So this stuff is very important for us. So can you see guys, if we inhibit ACE inhibitors, we are leading to increase in angiotensin 1, and this angiotensin 1 is not getting converted into angiotensin 2, which was deleterious to us. This angiotensin 1 क्या convert हो गया? It get converted into angiotensin 1,7, which has so many marvelous effects on our body. ठीक है? So this is how ACE inhibitors work as well. So ये जो सारे function हैं, they're actually cardioprotective, and that is the reason why ACE inhibitors are one of the most cardioprotective drugs that we have. ठीक है? So this is one thing. But just remember guys, हमारे पास angiotensin 4 भी है. हमने अभी बात की थी angiotensin 3 and angiotensin 4 की भी. So just remember, एक मैं चीज बताना चाहता हूँ, we don't have any drug which is working for angiotensin 4, but this angiotensin 4 has been found कि actually there is a receptor which is known as insulin regulated aminopeptidase. ठीक है? ये angiotensin 4 का receptor है, and whenever angiotensin 4 binds to this insulin regulated aminopeptidase, it inhibits this. Okay guys, so it's going to inhibit it. So whenever this it's going to bind to here, it's going to inhibit this IRAP, and इसके कारण क्या हो रहा है usually This IRAP was mediating conversion of your neuropeptides into smaller fragments. So now what is happening is I'm going to see a buildup of your active neuropeptides, and that is going to play a very important role in case of cognitive function and memory. Okay, so this is the role of your angiotensin 4. Okay, this was about the circulating renin angiotensin system. What about the local one? अब यहाँ पे आगे जब we explored further about this renin angiotensin system was it is not only in the blood, it is present locally in the tissues as well. So that is the first thing. तो दो है हमारे पास, we have extrinsic local RAS and we have intrinsic local RAS. What do I mean by that? Extrinsic local RAS का मतलब ये है कि एंजियोटेंसिनोजन अभी भी लिवर से आ रहा है और रेनिन अभी भी किडनी से आ रहा है. That's one thing. ठीक है, but where is it getting converted to its angiotensin 2? It's getting converted locally, not in the circulation. Okay, so this is known as extrinsic local RAS, and it's going to act locally as well. So you understand, guys? Liver say and kidney say, ultimately we have production of this angiotensinogen and renin. Okay, this doesn't get converted in the circulation. This might get into the tissues. So tissues के पास they have these enzymes over there which can convert your angiotensinogen and renin into ultimately your angiotensin 2. ठीक है, तो दिस रेनिन यहाँ पे आएगा, एंजियोटेंसिनोजन यहाँ पे आएगा, इट्स गोइंग टू गेट कन्वर्टेड लोकली ओवर देयर, एंड जो एंजियोटेंसिनोजन है अल्टीमेटली गेट्स कन्वर्टेड टू एंजियोटेंसिनोजन 2 एंड दिस एक्ट्स लोकली. सो दिस इज एक्सट्रिंसिक लोकल रास. However, there is one more mechanism that is known as intrinsic local RAS. मतलब जो सारे components हैं renin, angiotensin, aldosterone system के, whether it be angiotensinogen, whether it be angiotensin 1, 2 or renin, everything is being produced by the tissue itself. So that is why I'm going to say it as intrinsic. It has the intrinsic ability to synthesize everything that is required for RAS, and it's going to act locally. So this is the point. Many tissues possess the capacity to synthesize all the components of RAS. What are they tissues? Heart, blood vessels, brain and kidneys. Okay, and just remember, this angiotensin 2 और इसके जो भी downstream products हैं, they're going to play a very important role in cell function, cell growth, cell death, fibrosis and remodeling. ठीक है, and this is what we are very scared about. ठीक है, especially in case of heart failure, we are very scared about remodeling. We are very scared of remodeling in ischemic heart disease as well. So whenever we are going to inhibit this angiotensin 2, we're going to serve it as basically prevent your remodeling. Right. So let's discuss one more theoretical aspect, that is your pro-renin and pro-renin receptor. Okay. So what happens is, guys, we have a enzyme. It's a pro-enzyme that's your pro-renin. Okay. So usually this pro-renin has this pro-peptide attached to it, and this pro-peptide क्या कर रहा है? इस ये जो इसकी catalytic unit है ना, जो active site है, उसे block कर रहा है. ठीक है. That's one thing. Now what happens is, this pro-renin gets converted to renin via the action of these enzymes. These are pro-convertase 1 and cathepsin B, and ultimately it gets converted to the active product, that is renin. Okay, so pro-renin gets converted to renin via the use of these enzymes. Once ये जो हमारा pro-peptide है अब हट चुका है उसमें से, can it go attach back? No, it can't. So this is an irreversible activation of your renin, or I can say it as it's an enzymatic activation of your renin. Makes sense? Pro-renin gets converted to renin via which enzymes? Pro-convertase 1 and cathepsin B. That makes sense. But एक और हमारे पास mechanism ये है, that is known as the non-enzymatic one or the reversible one. What is that is? There is a receptor known as pro-renin receptor. ठीक है, so this is PRR. It's a pro-renin का भी receptor है ये, renin का भी receptor है, तो हम ऐसे ही लिखते हैं उसे. ठीक है, we write it as pro, we put it in brackets and we write it as renin receptor. ठीक है, so it means actually it's a receptor for both of them. So जब ये हमारा pro-renin है, when it binds to this pro-renin receptor, अब ये polypeptide which is earlier covering this active site, अब ये खुल जाएगा. ठीक है, it is not getting cleaved, and what can happen is angiotensinogen can bind here and get converted to your angiotensin 1. ठीक है, that's the first thing. But whenever the जो हमारा pro-renin है, when it dissociates away from the receptor, now what's going to happen is this is going to close again. So what have we done is, this is a form of reversible. So this is irreversible. I'm sorry, this is actually reversible. All right, so this is a reversible process. All right, guys, so this is a reversible process and this is the irreversible process. And how we know कि pro-renin, how does it get converted to renin? It can get converted via enzymatic pathways, or it can get converted via non-enzymatic or reversible pathways as well. ठीक है, and just remember guys कि whatever हमारे पास दो टाइप की सिग्नलिंग भी होती है, या तो हमारा जो ये रेनिन है, इट कैन पार्टिसिपेट वाया द एंजियोटेंसिन 2 डिपेंडेंट पाथवे, जो हमारा नॉर्मल है कि pro-renin आएगा, pro-renin gets converted to renin, the renin catalyzes the conversion of angiotensinogen into angiotensin 1 and further into angiotensin 2, and उसके जो भी downstream effects है वो angiotensin 2 mediate कर रहा है. But it was found we also have some alternate pathways as well, which are angiotensin 2 independent pathways. Okay, so just remember that. Okay, so these pathways are independent of that. So why am I telling you all of this is, because हमारे पास जो drugs हैं, that is your ACE inhibitors or ARBs, obviously ARBs are the one which are more preferred over here, and we will see why. Okay, just remember that. One more thing is diabetic nephropathy. It has been seen that this prorenin actually, because this prorenin can mediate many of the downstream effects, and हमने ये देखा है diabetic nephropathy में the ratio of prorenin to renin ratio goes up, and it is actually the prorenin portion which is leading to activation of these pathways, whether it be the MAP kinase pathway or whether it be the activation of plasminogen activator inhibitor type 1 or JAK-STAT pathway or different pathways. Okay, that's one thing. All right, so let's just see angiotensin 2 के क्या actions हैं. All right, so let's first talk about the cardiovascular system. So it's going to mediate vasoconstriction, but this vasoconstriction is less marked in cerebral, skeletal muscles and coronary vessels. Okay, how does it mediate that vasoconstriction? एक तो इसका direct action हो गया via angiotensin 2 receptor, which is the predominant one. Okay, angiotensin 1 and angiotensin 2 receptor के through it can mediate vasoconstriction. That's one. What else can it do? It can increase the adrenaline and noradrenaline coming from either the adrenal medulla or from the nerve endings. मतलब it's an indirect action. What else? It can increase the central sympathetic flow. It can prevent norepinephrine reuptake, as well as it can increase the vascular responsiveness to your angiotensin, to your other sympathetic nervous system activation. Okay. What else? It was seen angiotensin 2 can increase the contractility by mediating calcium influx. That's one. But actually, because it increases the afterload so much, it's going to decrease the cardiac output. And ultimately, what we were seeing, angiotensin 2 is very bad for us because it increases the cardiac work. Why is the cardiac work increases? Because the total peripheral resistance is increasing. Ultimately, जो भी इसके downstream effects हैं on the heart, what is it going to do? It's going to lead to hypertrophy of the heart. It's going to lead to hyperplasia, intercellular matrix production in the myocardium, as well as the vascular smooth muscle cells. और इसी portion को हम कहते हैं your remodeling. So this is what is happening. So remodeling of the myocardium is one portion that we have to discuss. And जो भी इसके कारण volume overload या pressure overload generate हो रहा है, so what do I mean by afterload जब increase करेगा, I'm going to see a pressure overload, and whenever the blood volume is increasing, I'm going to see a volume overload. So both of them are getting increased. इसके कारण I'm seeing hypertrophy will occur, whether it is volume overload hypertrophy or pressure overload hypertrophy. What are its action on the adrenal cortex? Is going to stimulate the production of zona glomerulosa पे जाएगा, and it's going to stimulate the production of this aldosterone. We've already discussed that. What about on the kidney? Kidney, whenever the aldosterone is working over there, it's going to lead to sodium retention and potassium excretion. Okay, potassium excretion. So it's going to lead to these things, as well as it's also going to lead to H positive loss as well. So this is also might be responsible for alkalosis. And we know why does that happen? Due to the sodium H positive exchanger present in the PCT. Okay, sodium ka reabsorption karayega, H positive gets lost, and that is why alkalosis might occur due to angiotensin 2. Right. Next thing, we talk about the CNS. Whenever CNS actions can mainly it's going to increase the thirst by acting on the osmoreceptors which are present over there. It's going to increase the ADH release as well, and it's going to increase the central sympathetic flow. Okay, as we know कि जो हमारे जो OVLT and subphonical organs है, यहाँ पे हमारे mainly osmoreceptors are present. ठीक है, OVLT stands for the organovasculorum lamina terminalis. This OVLT plays a very important role in your thirst pathway and your secretion of your ADH ultimately from the preoptic from your supraoptic nucleus. Okay, so OVLT and subphonical organs are which things they are known as circumventricular organs. ठीक है, why they're circumventricular? मतलब they don't have any blood-brain barrier over them. तो ये जो angiotensin 2 जैसा जो peptide जो है, it can directly act on this OVLT and subphonical organ and increase thirst and increase ADH secretion so that हम free water reabsorption को increase कर सकें. That's one. What about the receptors which are present over there? Angiotensin 1 receptor is the predominant one, and angiotensin 2 receptors is usually present in the fetus. Okay? So angiotensin 1 receptor is mainly a GQ linked receptor. I want you to remember that because ये जो सारी vasoconstriction वगैरह हो रही है, or whether it is the secretion of your aldosterone, it's all a GQ linked pathway. Okay? GQ receptors are mainly. Angiotensin 2 receptors mainly have the opposite effects. Okay? They might be present in the endothelium and the adrenal medulla, and they have the exact opposite effects as compared to your angiotensin 1 receptor. But if angiotensin 2 works on the angiotensin 2 receptor, it's going to lead to vasodilation and a decrease in blood pressure. It's going to stimulate apoptosis and inhibit the proliferation, which is the exact opposite of your angiotensin 1 receptor. Okay? अभी हमने एक और बात की थी already, guys, कि whenever we give a drug like ACE inhibitors or ARBs, what's going to happen is this angiotensin 2 is going to decrease. And I was telling you guys, this angiotensin 2 is exerting a negative feedback mechanism on your angiotensin 1 receptor which are present over the JG cells, and उसके through renin वो कम कर रहा था usually. But whenever this doesn't happen, and I'm going to see it, what am I going to see is, whenever this doesn't happen, I'm going to see a fall in the angiotensin 2. Why is that happening? Because I'm using some drugs like ACE inhibitors. So जब angiotensin 2 अगर कम होएगा, this negative feedback mechanism is abolished, and इसके कारण, right, what can happen is I'm going to see an increase in renin. So that's what is happening. What else? if we use the vasodilators and diuretics, okay, in a patient of CHF, you're going to use vasodilators and diuretics very frequently. So what is going to happen is uske karan blood pressure is going to drop, and we know blood pressure whenever it drops, either via the RAS mechanism predominantly, or via the sympathetic nervous system, I'm going to see an increase in renin as well. Okay, so just remember, guys, whenever I'm going to use these ACE inhibitors and antihypertensives, they're going to exert their maximum action in patients who are either on diuretics or they're mainly in CHF. तो उनमें ही मैक्सिमम एक्शन आएगा, एंड दिस इज व्हाट आई एम कंसर्न्ड अबाउट, बिकॉज उसमें ब्लड प्रेशर जो एस इनहिबिटर्स कम करेंगे, दैट्स गोइंग टू बी अ वेरी सिग्निफिकेंट अमाउंट. इस करके when I'm going to start ACE inhibitors in a patient who is either a CHF वाला patient who is already on vasodilator therapy or diuretics, I'm going to start with a lower dose so that उसे वो first dose hypertension ना हो. ठीक है, that's the important thing. Just remember, guys, loop diuretics जो है हमारे, they basically prevent the entry of your sodium into the macula densa, and indirectly they might increase your renin. ठीक है, beta blockers, because they're blocking renin, they're going to decrease your renin. And what about NSAIDs? NSAIDs are going to inhibit your COX enzyme, and this COX is actually very important for producing these prostaglandins, which are responsible for renin secretion. So just remember that, guys. Okay. So what are the different drugs which are acting on the RAS mechanism? Is we can have sympathetic blockers like your beta blockers and central sympatholytics. उसके कारण we're going to see a decrease in the renin. ठीक है? We can have direct renin inhibitors जिसमें हमारा एक ही drug है, that is aliskiren. We can have ACE inhibitors. We can have angiotensin receptor blocker, which is going to block the angiotensin 1 receptor, or it's going to block the angiotensin 2 receptor as well. We have drugs against that as well, but mainly predominantly angiotensin 1 receptor के लिए वो ज़्यादा specific है. And last में we can have the aldosterone antagonists like spironolactone and eplerenone, which is working on your aldosterone receptor. Okay, right? So let's talk about ACE inhibitors, guys. So whenever I'm going to talk about this ACE enzyme, actually this is a very non-specific enzyme. Okay, so ये जो सारे products which is in front of you guys, that is either it is angiotensin 1, उसको convert करना into angiotensin 2, job किसका है, ACE का, or whether it is a degradation of these products. What are these products? Bradykinin को degrade करना, या enkephalins, that is opioids को degrade करना, या stem cell regulatory peptide को degrade करना. That is all the action of this ACE enzyme. And whenever I'm going to inhibit this ACE enzyme, what's going to happen is ये सारे products are going to increase. So bradykinin is going to increase. And this is very important for us because bradykinin actually is very responsible for this brassy cough that we see in ACE inhibitors. And some cases of angioedema has also been reported to this increase in bradykinin. So this is important. Okay? So we have captopril. The first prodrug जो हमारा, that is your captopril. So just remember, ACE inhibitors, they actually increase the bradykinin, और इसके कारण has been seen the hypotensive effect is also further potentiated because bradykinin is a very important vasodilator in our body. ठीक है, very importantly. But just remember, ये जो हमारा जो पोर्शन है कि ACE inhibitors, do they actually work on this principle only कि bradykinin increase करने के कारण hypertension? Obviously not, because this is a very lesser role. It plays a very less role because actually जो हमारे bradykinin है, they don't only have ACE at their disposal. They also have an enzyme which is known as kinase 1, which can degrade them. Okay, so it's not आपने ACE को inhibit कर दिया, bradykinin will surely go up, but that bradykinin इतना ज़्यादा नहीं जाएगा. That's going to be responsible for your hypertensive effect. It might play some role, but not a major role. Okay, and I see whenever an increase in kinin is there, I'm going to see cough and angioedema. And just remember, guys, fall in blood pressure is more marked in those patients जिसमें already sodium depleted है and renin, angiotensin, aldosterone system is already active. So whatever is already active, अगर आप उसे vehemently अगर आप उसे inhibit करोगे, it's going to lead to a further decrease in your blood pressure. ठीक है? So just remember, greater fall in blood pressure has been seen in renovascular hypertension, and this is the point, guys. Primary or essential hypertension, which we normally say, okay, which is idiopathic, मतलब it doesn't have a secondary cause. 20% of these patients have been found to have a RAS which is overactive, and 60% of these patients have been found to have a RAS which is normal. तो हमारे पास basically 80% patients हैं जिसमें we can exert any kind of an antihypertensive effect. ठीक है? So these 80% people, some 20% people में actually the RAS is underactive. तो उसमें ACE inhibitors are not functioning very well. Okay, that's the thing, guys. As we saw कि हम जब ACE को inhibit करेंगे, I'm going to see a build-up of renin, I'm going to see a build-up of angiotensin 1, but more importantly, I'm going to see a build-up of this angiotensin 1,7, which was getting converted from your angiotensin 1 via the ACE2 enzyme because I'm inhibiting ACE1. Okay, so this angiotensin 1,7 was very important by exerting all of these cardioprotective effects. Okay, what am I going to see? I'm going to see a decrease in the total peripheral resistance. I'm going to see a decrease in the systolic blood pressure, and I'm going to see a decrease in the diastolic blood pressure as well. The cardiac output is going to be normal. The cardiovascular reflexes जो भी हमारे predominantly हमारे जो baroreceptor reflex है, which usually kick in when we are going to stand ultimately, they are not affected. मतलब अल्फा ब्लॉकर्स में जो हमने पढ़े थे, that is prazosin वगैरह अल्फा 1 ब्लॉकर्स जो थे, उसमें we were characteristically seeing as a side effect that was postural hypertension. ठीक है, because उसमें हम sympatholytic drugs दे रहे थे, because these are not actually sympatholytic drugs. Cardiovascular reflexes are not interfered. I'm not going to see the postural hypertension that was associated with alpha blockers. Okay, so no postural hypertension, little dilatation of the capacitance vessels. So कोई भी postural hypertension या first dose hypertension, I'm not going to see that. Okay, just remember alpha blockers, because they were also blocking the alpha 2 blockers. They were तो इस करके they were causing reflex tachycardia. But इसमें I'm not going to see the reflex tachycardia. मतलब they're very safe to give in even patients who are ischemic heart disease वाले patients. ठीक है, and just remember guys, it's going to decrease proteinuria, and ACE inhibitors have a very important renoprotective effect as well. ठीक है, so what are the adverse effects? I can see sometimes hypertension can happen, and I told you guys hypertension उन्हीं patients में होगा who are either a patient of CHF who is probably maybe on diuretic. So उस case में क्या होता है, that patient is already sodium depleted और उसमें renin levels are very high, and whenever you're going to give ACE inhibitors, वो balance जो है वो ज़्यादा disturb होएगा. ठीक है, one thing. The second adverse effect is hyperkalemia, especially in patients who have impaired renal function, or patients who are on potassium supplements, or patients who are on potassium sparing diuretics or beta blockers or NSAIDs. ठीक है, तो उनमें hyperkalemia is a very important risk. Brassica, if I told you, due to kinins. Rashes, urticaria, and angioedema can again occur due to buildup of your bradykinins. I'm going to see dysgeusia, alteration in taste and smell. These drugs are very teratogenic, whether it be ACE inhibitors, whether it be ARBs, or whether it be your direct renin inhibitors. तीनों की तीनों are contraindicated in pregnancy. ठीक है, and as a very rare side effect, I'm going to see granulocytopenia. One more contraindication of your ACE inhibitors is bilateral renal artery stenosis. Why is that, guys? Because what happens is this ACE inhibitors or ARBs actually ये क्या करते हैं, यूजुअली दिस एंजियोटेंसिन 2 जो है ना, इट मेनली वर्क्स एट द इफरेंट आर्टेरियोल. हमने अभी बात की, व्हेनेवर इट्स गोइंग टू कंस्ट्रिक्ट द इफरेंट आर्टेरियोल, उसके कारण मतलब इफरेंट आर्टेरियोल का जब रेजिस्टेंस बढ़ता है इफरेंट आर्टेरियोल का, आई एम गोइंग टू सी एन इंक्रीज इन द जीएफआर. यू ऑलरेडी टॉक्ड अबाउट दिस. ठीक है, अब पेशेंट इज ऑलरेडी ए केस ऑफ रीनल आर्टरी स्टेनोसिस, मतलब ऑलरेडी उसका ब्लड फ्लो कम आ रहा है वाया द इफरेंट आर्टेरियोल. ठीक है, तो जीएफआर ऑलरेडी उसका शायद कम होगा. व्हाट आई एम डूइंग राइट नाउ इज मैंने एस इनहिबिटर्स एआरबीज दे दिए, एंड इसके कारण जो भी मेरी इफरेंट आर्टेरियोल कंस्ट्रक्शन पहले हो रखी थी, विच इज नॉर्मल, जितनी भी टोन थी उसकी, जिसके कारण जीएफआर थोड़ा इंक्रीज हो सकता था, मैंने उसे भी ब्लॉक कर दिया है. नाउ दिस एफरेंट आर्टेरियल इज अंडरगोइंग वेसोडाइलेशन, एंड आई एम नॉट गोइंग टू सी व्हाट, इसके कारण मेरा जीएफआर इज गोइंग टू डिक्रीज ट्रेमेंडसली, एंड द पेशेंट इज गोइंग टू लैंड अप मे बी इन acute kidney injury as well. ठीक है, so contraindication very importantly is either your pregnancy and your bilateral renal artery stenosis. ठीक है, what are some other interactions? हमने बात की, diuretics actually synergize the action of your ACE inhibitors because patients will be sodium depleted. NSAIDs जो है actually are going to inhibit the action of these ACE inhibitors because they're going to cause salt and water retention. Potassium supplements and potassium sparing diuretics हमने already study किया है. If we give ACE inhibitors in these patients, might see an episode of hyperkalemia. And ACE inhibitors are very importantly because they lead to they're going to decrease your lithium clearance, so that might suffer as की lithium की toxicity हो सकती है. What are the dose that we start with? Usually अगर captopril की बात हो रही है, we're going to start with 25 milligram BD, and then we can go up till 50 milligram TDS. ठीक है, just remember we're going to half this dose or even quarter it up when we have patients that is who are suffering from either they're on diuretics or it's a patient of your congestive heart failure. उस केस में सोडियम डिप्लीशन बहुत ज्यादा है. I'm going to start with 6.25 milligrams and then build it up. And these drugs have to be taken 1 to 2 hours before or after a meal, especially in case of your captopril. Then I have some other drugs. थोड़े छोटे points हैं उनमें. The next one is enalapril. Enalapril, just remember it's a prodrug. Okay, it's more potent as compared to your captopril. It's longer acting. Onset इसका slower है, and hence it has less first dose hypertension, which is associated with your captopril. The next drug that I have is lisinopril. Just remember guys, we have to यहाँ पे याद रखने, captopril and lisinopril are not prodrugs, they're active. ठीक है, enalapril is prodrug. ठीक है, so lisinopril is active. Again, the next drug that we have is perindopril. Perindopril is again an inactive form, मतलब एक prodrug की तरह हम administer करते हैं, and gets converted into the body into this perindoprilat. That is your जो active component, active metabolite. That's perindopril for you guys. Then you have fosinopril. Again, fosinopril is also a prodrug. ठीक है, बस बात ये है, usually ACE inhibitors की क्या खासियत है, usually they are excreted by the kidney. ठीक है, so you have to watch out for patients who are renally impaired. उसमें आपको डोज थोड़ा कम करना पड़ेगा. But this fosinopril is special because it is metabolized both by the liver and the kidney. इसके कारण it does not need any dose alteration in case of renal impairment. Then we have ramipril. ठीक है, ramipril की बस ये बात है, it has an extensive tissue distribution, so that has been seen. तो जो local RAS को inhibit करना जो ज़्यादा जो tout किया जाता है as its Advantage over other ACE inhibitors is that ramipril has extensive tissue distribution. Then we have other drugs like quinapril, we have tandalopril, imidapril, and benazepril. So these are the different drugs. The uses, we know we can use it in hypertension, we can use it in congestive heart failure, we can use it for after an episode of MI. Okay? We can use it as a prophylaxis in high cardiovascular risk patients, even if they don't have any hypertension, because these ACE inhibitors are very cardioprotective. We can use that in diabetic nephropathy because it has been seen they decrease the amount of proteinuria which occurs in them. And very importantly, guys, scleroderma crisis may we use ACE inhibitors frequently. Okay, so that is the first drugs for you guys. The next are your ARBs. ARBs are the exact similar. सारे action इनकी similar है. So सीधा we're going on to your drugs only. So the first drug that I have for you in case of angiotensin receptor blocker is losartan. Okay, losartan is specifically 10,000 times it's more sensitive for angiotensin 1 as compared to angiotensin 2. And we know guys कि angiotensin 1 is the predominant action that we don't want. ठीक है, because angiotensin 1 ही हमारे जो भी गड़बड़ वाली चीजें थी वो सारे angiotensin 1 करा रहा था, whereas angiotensin 2 was still some protective role था उसका. So this is going to block angiotensin 1. It's an antagonist as well as it's going to be an inverse agonist as well. मतलब जो constitutive action है उसी को भी और वो inhibit कर सकता है. ठीक है, that's the first thing. It might function as it might also block your thromboxane A2 receptor, so it is antithrombotic as well. And just remember, all actions of angiotensin 2 are blocked. But the फायदा क्या है इसमें, there's not going to be any rise in bradykinin or not going to be any rise in substance P. तो इसके कारण I'm not going to see any cough, I'm not going to see any angioedema which is associated with ACE inhibitors. ठीक है, very importantly. And just remember, but एक problem ये है, ACE inhibitors में I was seeing an increase in this very important peptide that is angiotensin 1,7, which is very cardioprotective. इसमें I'm not going to see that, ठीक है, because ACE inhibited नहीं है, तो there is not a build up of your angiotensin 1 there, ठीक है, तो इसके कारण little increase will be in angiotensin 1,7. Heart rate is going to stay normal. Cardiovascular reflex again इसमें भी normal है, तो no postural hypertension, no reflex tachycardia, everything is same. And losartan even has your losartan has a uricosuric action as well. ठीक है, just remember guys, whenever losartan gets into the body, when it goes to the liver, it gets converted to this active metabolite which is almost 10 to 30 times more potent than your losartan. ठीक है, right. Excretion क्या mainly इसका kidney का है. And what are the adverse effects? Just remember adverse effects क्या क्या हमारे, hypertension again it's less likely, hypoglycemia can occur. I told you the situation किसमें हो सकता था वो, there is no cough, there is no dysgeusia, but obviously it is teratogenic. The next drug that I have for you is candesartan. कैंडेसार्टन का भी मेन बस इसका ये एक वो है कि इसका टी हाफ इज वेरी हाई बिकॉज इट हैज अ स्लो डिसोसिएशन फ्रॉम द रिसेप्टर्स, तो इसका काफी ज्यादा लॉन्ग टी हाफ है. देन वी हैव अदर ड्रग्स लाइक इर्बिसार्टन, वी हैव वालसार्टन, ठीक है, देन वी हैव ओल्मेसार्टन, ठीक है, ऑल ऑफ दीज ड्रग्स आर देयर. टेलमिसार्टन एंड एप्रोसार्टन, दीज आर द डिफरेंट ड्रग्स दैट वी हैव. ठीक है, राइट. So now, आजकल recently they're saying that we should actually combine your ACE inhibitors from ARBs. We've already not seen that. हम already पढ़ते हैं कि ACE inhibitors and ARBs, if you're going to combine, they're going to potentiate your action and that might lead to hyperkalemia. But it has been seen ACE inhibitors and ARB therapy, if you're going to give them together, they have some theoretical aspects. से अगर हम बात करें, they're going to have some wonderful effects. Let's see that. First thing is, जो हमारा bradykinin buildup हो रहा है, right? When we going to ACE inhibit अगर हम करते हैं, I told you guys कि bradykinin के buildup के कारण I'm going to see hypertension. I'm not hypertension actually, vasodilatation. So this bradykinin is also very important for us. Okay, so that is the first thing. It's going to improve your BP control. It's going to lead to provide more complete RAS blockade when I'm going to combine ACE inhibitors with your ARBs. That's the first thing. What else? Angiotensin 2 can be generated by non-ACE mechanisms. This is the thing, guys. Angiotensin 2 जो है, it's not only कि ACE से ही वो convert हो सकता है into your further products as angiotensin 1 or 2. Angiotensinogen can get converted into angiotensin 1 and 2 by other enzymes as well, rather than ACE, like kinase and trypsinogen. ये सारे enzymes भी cover कर सकते हैं. So we need a drug which is actually going to block the receptor. तो उस केस में अगर हम ACE inhibitors और ARBs को दोनों को completely block करेंगे, then I'm going to see a more complete blockade of this whole system. ठीक है? What else? ACE inhibitors were leading to increase in bradykinin, which is good for us, increase in angiotensin 1,7, which was also good for us. तो ये हमारी good news है. And what about that? अगर just remember, ARBs are actually going to increase your angiotensin 2 के levels. And how am I going to prevent that from happening? I'm going to give ACE inhibitors. So अगर मैं ACE को inhibit कर दूंगा, I'm going to see more of angiotensin 1 and less of angiotensin 2, which is good. So ये complete rationale है why are we using both of them together if you want to use them in CHF. ठीक है? Right. Then we have last drug जो इसमें RAS inhibitors में we have, that is your direct renin inhibitors. Something about that, mainly हमारे aliskiren है. It's a non-peptide, 9 amino acid का peptide है. And what's it going to do? It's going to bind to the catalytic site of this renin and competitively block the access of your angiotensinogen, so that angiotensinogen doesn't get converted to an angiotensin 1. So इसका main action है. ठीक है? So renin के levels are actually going to go up, but the plasma renin activity is going to go down. Angiotensin 1 की levels भी low रहेंगे, angiotensin 2 की level भी low रहेंगे, because all of these are upstream. These are downstream products, है ना. Renin से ही angiotensin 1 बनता है, तो that's also going to be low, and angiotensin 1 से angiotensin 2 को बनता है, that's also going to be low. So this ये जो drug है हमारा, that is aliskiren, it leads to natriuresis, we know it leads to potassium retention as well, और इसकी equivalent antihypertensive efficacy है as compared to your ACE inhibitors or ARBs, ठीक है. But अभी we are not using that this often, and just remember it's again contraindicated in your pregnancy. So these were the one set of drugs that we talked about. The next drug that I have for you are your nitric oxide, ठीक है. Just remember guys, हमारा smallest endogenous signal molecule is your nitric oxide, and this is a gas at your normal temperature. And हमने already nitric oxide बहुत frequently हमने पढ़ा था when we were studying nerve muscle physiology and how is it mediating your smooth muscle relaxation, ठीक है. So what happens is this L-arginine, ठीक है, gets converted to L-citrulline via this enzyme that is known as nitric oxide synthase, ठीक है. And it also requires NADPH and these set of coenzymes as well, that is FMN, FAD, that tetrahydrobiopterin and heme, ठीक है. ये पूरा रिएक्शन जब कंप्लीट होएगा, L-arginine gets converted to L-citrulline and I'm going to see a release of nitric oxide, okay. This nitric oxide is of three types. We can have neuronal nitric oxide synthase, we can have inducible nitric oxide synthase, and I can see endothelial nitric oxide synthase. Inducible nitric oxide synthase I have seen in immunology. मतलब this जो हमारा inducible nitric oxide synthase है, this is mainly going to be present in the phagocytes, ठीक है. And why am I saying this as inducible? Because मेरे सारे bacterial endotoxins, मेरे सारे interferons, या not interferons, maybe your सारे cytokines और TNF alpha can induce this nitric oxide synthase, produce more amount of nitric oxide, and we know nitric oxide can combine with oxygen or your superoxide and get converted into peroxynitrite, okay. And this peroxynitrite, which is a free radical, is going to lead to bacterial lysis, okay. So this is your antimicrobial effect of your nitric oxide. जो remaining है हमारे, that is neuronal nitric oxide synthase and endothelial nitric oxide synthase, they're mainly dependent upon your calcium for work functioning. But any drug which is going to increase your calcium in the endothelium will ultimately lead to increased amount of nitric oxide synthesis. मतलब जो भी मेरे GQ linked receptors हैं, whichever drugs they might be, they're going to increase nitric oxide synthase, ठीक है. That's the first thing. Just remember guys, it's going to exist in the tissues only for 10 to 40 seconds, okay. And what's going to happen is the nitric oxide might get combined with oxygen, gets converted to nitrite, or it might get combined with hemoglobin, gets converted to nitrate, and these nitrites and nitrates are secreted in the urine, and this is the action which occurs in the body, okay. So this is what I'm telling you guys. And how will it lead to smooth muscle relaxation, okay. This nitric oxide actually, which is generated from the endothelium, okay. So ये जो endothelium से release हो रहा है nitric oxide, I'm going to call it as endothelial derived relaxing factor, that is EDRF, okay. So ये जो EDRF है, that nitric oxide being a gas, it's going to go via the lipid membrane and reach the smooth muscle cell. वहाँ पे क्या करेगा? It's going to stimulate guanyl cyclase. This guanyl cyclase is going to increase the cyclic GMP production. That's going to activate your protein kinase G, and this protein kinase G is going to phosphorylate a very important enzyme. क्या है हमारा? Myosin light chain phosphatase, ठीक है. This myosin light chain phosphatase is going to cleave the myosin light chains में से phosphate, so that this myosin light chain is without the phosphate and it is not able to combine with your actin. And what am I going to see? I'm going to see smooth muscle relaxation. Okay, that is important for us. All right, guys. So what are the actions? हमने already पढ़ा. Vascular system पे leads to vasodilation, and we've already seen why does it do that? By the activation of your MLCP via protein kinase G pathway. ठीक है. Platelets पे क्या action है nitric oxide की? It mainly inhibits aggregation of platelets. It is anti-atherogenic and it decreases the addition of leukocytes as well as migration of these leukocytes. ठीक है. अगर infection होता है, we know inducible nitric oxide जो है, this nitric oxide gets combined with your superoxide, and what will it form? It will form your peroxynitrite. ठीक है. And just remember, because this nitric oxide is pro-inflammatory, it's very good for us in case of infection. And just remember, एक और चीज, pathophysiologically speaking, nitric oxide level, ठीक है, have been implicated as a study in case of your bronchial asthma. ठीक है. Bronchial asthma में we measure the nitric oxide, that is fractional excretion of FeNO. We can measure this nitric oxide levels, and उसके accordingly we can check whether the corticosteroid जो हम दे रहे हैं, whether their efficacy उनकी है या नहीं है. So that is in bronchial asthma. ठीक है. So this is what is happening, guys. Ki how is it mediating your relaxation? Smooth muscle cell relaxation is occurring. And I told you guys this time when we were discussing acetylcholine as well. Ki acetylcholine, when it works on the endothelium, मतलब endothelium अगर intact है, is going to release nitric oxide. That's first. But अगर denuded हो जाए endothelium, then this acetylcholine can work directly on the muscarinic receptors present on the smooth muscle cell, and that will lead to vasoconstriction. ठीक है? All right. What about CNS? CNS में just remember guys, nitric oxide plays a very important role in synaptic plasticity and especially long-term potentiation. Okay, so just see about that. How does it do that? All right, and it has been also seen that nitric oxide it actually stimulates your excitotoxic damage which occurs to the glutamate neurons. Okay, we already saw in erection pathway as well. Erection में we have some neurons which are known as NANC neurons, that is non-adrenergic, non-cholinergic neurons, and they're not going to release acetylcholine. They're Hello guys, so sorry for the disturbance. And nitric oxide, as you all know, it also plays a very important role in your enteric nervous system as well. Okay, lungs में क्या है? Lungs में nitric oxide plays a very important role in your regulation of your pulmonary vascular resistance. And it has been seen this nitric oxide levels might be depressed in your pulmonary arterial hypertension. And that is the reason why I want to use this drug, which is known as sildenafil, which is what? Which it's going to inhibit your phosphodiesterase 5. उसके कारण I'm going to see an increase in cyclic GMP. ठीक है? So that is going to be mediating your pulmonary vasculature ka dilatation, and I'm going to prevent pulmonary arterial hypertension. Okay, sildenafil I can use that. So what are the different nitric oxide donors that I have? So I have GTN, that is glyceryl trinitrate. So what happens is the GTN gets converted to nitric oxide via this enzyme which is known as mitochondrial aldehyde dehydrogenase. Okay, and just remember guys, this GTN is preferentially present in the veins. That is the reason why it's going to function mainly as a vasodilator, and I'm going to see a reduction in the preload predominantly, not an action mainly on the afterload, a reduction in the preload. And we know guys कि preload का reduction, how does it work? Mainly it's going to decrease the volume work of the heart. ठीक है, तो अगर ये volume work अगर heart का decrease होएगा, and hence I can see कि जो हमारे oxygen supply demand mismatch है, that's going to get relieved. And that is why this GTN is a very important anti-anginal drug as well. We have others as well. We have isosorbide dinitrate and we have isosorbide mononitrate. These are oral drugs, and इनका बस बात ये है that they are again slower acting and they produce something known as tolerance. And why does this tolerance occur is because ये जो drugs हैं, again they're going to use this enzyme which is mitochondrial aldehyde dehydrogenase. But what happens eventually is जब हमारा nitric oxide produce होएगा, it's going to generate some free radicals, and these free radicals are going to inhibit this enzyme itself, so that further conversion of these products are not going to occur. And उस चीज को हम क्या कहते हैं? We're going to call it as tolerance. We have developed tolerance to that drug. Okay, that's important. Next, this is what I was telling you about. Okay, why does nitrate tolerance occur? So you can study it on your own, and how can it happen? So one reason I've told you about is the inhibition of this mitochondrial aldehyde dehydrogenase, which is occurring due to the production of free radicals. Okay, right. We have other nitric oxide donors as well. We have amyl nitrate and we have also sodium nitroprusside. So sodium nitroprusside mainly we give it in an IV infusion, and इसकी बस characteristic बात ये है that it functions both as an arteriodilator as well as a vasodilator. ठीक है, so again this is very important for your acute decompensated maybe heart failure. ठीक है, sodium nitroprusside. All right. Next, now we're going to talk about the vasoactive peptides जो हमारे और रह गए हैं. ठीक है, so this chapter is nitric oxide and vasoactive peptides. So what are the vasoactive peptides do I have? Vasoconstrictors में I have angiotensin 2, I have endothelin, neuropeptide Y, and urotensin. I have already told you guys urotensin is the most powerful vasoconstrictor present in our body. What about the vasodilators? I have kinins, I have natriuretic peptides, mainly ANP, BNP, CNP. I have vasoactive intestinal peptide, substance P, न्यूरोटेंसिन, CGRP एंड एड्रेनोमेडलिन. सो ये हमारे सारे वेसोएक्टिव पेप्टाइड्स हैं. लेट्स सी थोड़े थोड़े जो कि इसके बारे में कैरेक्टरिस्टिक चीजें हमें पता होनी चाहिए. द फर्स्ट वन इज एंडोथेलिन. वी कॉल इट एज एंडोथेलिन बिकॉज इट ड्राइव फ्रॉम द एंडोथेलियल सेल्स. दैट्स द फर्स्ट थिंग. ठीक है, जस्ट रिमेंबर गाइस, एंडोथेलिन आर ऑफ मेनली 3 टाइप्स, बट जो मेनली हम जो पढ़ते हैं दैट इज एंडोथेलिन टाइप 1, ET1 हम उसे कहते हैं. दैट इज द मेन वन दैट आई वांट यू टू नो. वेयर इज इट प्रेजेंट ऑन द वास्कुलर एंडोथेलियम. ठीक है, and how do these endothelins are produced is mainly they get produced from pre-pro endothelin 1. This pre-pro endothelin 1 जो है gets converted to big endothelin 1, and this big endothelin 1 gets converted to endothelin via this enzyme that is endothelin converting enzyme. Okay, so this is the endothelin synthesis which occurs in the endothelial cells. Just remember guys, shear stress which occurs, it's going to mediate increased amount of endothelin production as well as these pro-inflammatory cytokines as well. Okay, whereas जो हमारे vasodilatory जो भी substances हैं like nitric oxide or prostacyclin, they're going to decrease the amount of endothelin synthesis which occurs. ठीक है, alright. What are the different receptors that we can target for drugs? We have 2 types of receptors. We have endothelin type A receptor, we have endothelin type B receptor. ठीक है, हमने कहा था 3 टाइप के एंडोथेलिन है. तो एंडोथेलिन टाइप A receptor has affinity for endothelin type 1 and 2, and endothelin type B has equal affinity for 1, 2 and 3. पर अभी हमें बेसिकली क्या पढ़ना है, वी नीड टू स्टडी एंडोथेलिन टाइप ए रिसेप्टर, जो हमारा मेनली इज गोइंग टू बी ब्लॉक्ड बाय सम ड्रग्स, ठीक है. सो दिस एंडोथेलिन टाइप ए रिसेप्टर इज प्रेजेंट ऑन द स्मूथ मसल सेल्स, जहां पे इट्स गोइंग टू मीडिएट वेसोकंस्ट्रिक्शन. सो दिस इज इंपॉर्टेंट फॉर अस. सो लेट्स सी. सो व्हाट आर द एक्शंस ऑफ एंडोथेलिन. फर्स्ट, अगर हम किडनी की अगर हम बात करें, they're going to lead to vasoconstriction. So renal blood flow is definitely going to decrease. अगर renal blood flow अगर कम होएगा, I'm going to see a decrease in the GFR as well. ठीक है, so that is the kidney पे effect. What about the CVS? CVS में I'm just seeing that I'm going to see an increase in the blood pressure. ठीक है, increase in the blood pressure that is occurring. I might also see a positive inotropic and chronotropic action of your endothelin action. ठीक है, all right. What next? And one more thing importantly, guys, respiratory system में they're going to lead to contraction of your tracheal and bronchial smooth muscles as well as the vasculature as well. ठीक है, तो pulmonary vasculature को भी endothelin जो है basically lead to vasoconstriction of that vasculature, and hence I can use some blockers, that is endothelin type A blockers. I can use it in a condition that is known as pulmonary arterial hypertension, जहाँ पे मुझे वो vasoconstriction वो कम चाहिए, मुझे वो resistance कम चाहिए. I don't need that pulmonary vascular resistance, that is PVR. ठीक है, all right. So these are the blockers we have. Endothelin receptor blockers हमारे पास दो टाइप के एक्चुअली. Forget all of this about endothelin type B receptor antagonist. We don't need to study that. We can have dual antagonist जो कि endothelin A, B दोनों को block करेंगे, और we can have selective endothelin A receptor blockers. ठीक है, dual antagonist में I have bosentan and I have macitentan. So this bosentan and macitentan are dual antagonists, whereas जो हमारे selective endothelin type A receptor antagonist है, very importantly I have ambrisentan, I have sitasentan, I have atrasentan. Okay, so all of these drugs, where I use them for, I use them in pulmonary arterial hypertension, that is PAH में use कर सकता हूँ. Recently there have been studies which use them in CHF as well. ठीक है, so what are the adverse effects? Mainly क्या होगा, अगर मैं vasoconstriction को inhibit कर रहा हूँ, तो mainly I'm leading to vasodilation. So I'm going to see every effect that's going to occur due to vasodilation. What are they? Might see headache, I might see nasal congestion, flushing, palpitations, edema might occur. Bosentan के साथ it has been seen that it leads to increase in ALT and AST levels. ठीक है, I might see anemia. Chronic anemia can occur with endothelin receptor blockers. And just remember, guys, these drugs are also contraindicated in pregnancy. ठीक है, all right. Right, guys. In case of pulmonary arterial hypertension, recently it has been said कि now we have other prostacyclin pathway as well. तो prostacyclins क्या हमारे PGI2. तो we have some PGI2 analogs which will also use in pulmonary arterial hypertension. And उसमें से I want you to remember that is epoprostenol. ठीक है, epoprostenol we can use it as a continuous IV infusion, and this has been recently approved in your PAH. ठीक है, so we have all of these drugs like iloprost हो गया and treprostinil हो गया. So these drugs they work by the prostacyclin pathway. अभी हमने कौन सा pathway पढ़ा था? That was the endothelin pathway, and how we can have selective endothelin A receptor antagonist like ambrisentan, or we can have dual ET receptor antagonist like macitentan. ठीक है, so this was used in PAH. The next thing that I have for you is neuropeptide Y. I just want you to remember mainly neuropeptide Y functions in the sympathetic nervous system, and it also functions as a neurotransmitter in the brain. ठीक है, what I want you to remember in case of neuropeptide Y is very important for your food regulation, guys. ठीक है, food regulation के it's very important. मतलब it's an orexogenic neurotransmitter. मतलब whenever the neuropeptide Y के levels अगर increase करेंगे, I'm going to see stimulation of my feeding center and not an inhibition of my satiety center. Okay, this is important. I've already told you guys, urotensin, already known as urotensin 11 amino acid का peptide है, and it is the strongest known vasoconstrictor. Where is it located in? It's located in the cholinergic neurons of your brainstem, spinal cord, kidneys, heart, and lungs. So this is the most powerful vasoconstrictor that I have. Okay. What next? And now I'm going to talk about the vasodilators. So vasoconstrictors done okay, and now I'm moving on to your vasodilators. So what are they? First, I have kinins. I've already seen something about kinins. Just remember, guys, kinin जो हैं, they are my vasodilators. Okay, don't make a mistake. Okay, how can I tell you that is? Do you remember, guys, angioedema में what plays a role? Bradykinin. So do you see bradykinin में we see flushing, है ना? We see congestion, we see swelling up of the mucosa, है ना? Swelling up of the lips. So all of that is mediated by vasodilatory action. So please don't confuse when I say that kinins are vasodilatory. ठीक है? So ये थोड़ी problem हो जाती है. So let's see how are the kinins getting synthesized. What are the different kinins do I have? I have bradykinin, that is BK, or I have lysyl bradykinin, that's also known as calodin. ये मेरे पास दो vasoactive peptides हैं, that is that's your kinins. How is this synthesized? Let's see that. So we have something known as high molecular weight kininogen. This high molecular weight kininogen gets converted to bradykinin via this enzyme, I would say, that is kallikrein. Okay, so this kallikrein factor is going to convert a high molecular weight kininogen into bradykinin. And how is this kallikrein getting converted? This kallikrein exists as pre-kallikrein. This pre-kallikrein is usually getting converted into kallikrein into its active form via what? Via Hageman's factor. That is factor number 12 of the clotting pathway. Okay. So this Hageman's factor convert plasma pre-kallikrein into plasma kallikrein. This plasma kallikrein converts a high molecular weight kininogen into bradykinin. Okay. What about Nietzsche? We have the no molecular weight kininogen, which gets leads to calidin. And these things are also interconvertible via this enzyme known as aminopeptidase. Okay. So this is the whole pathway that is occurring over here. Okay. So we discussed about bradykinin, we discussed about calidin, and हमने ये बात की कि high molecular weight kininogen, how they're getting converted into bradykinin by something known as plasma kallikrein. Just remember, guys, यहाँ पे we have also one inhibitor which is known as C1 esterase inhibitor, that is C1NH. Why am I telling you guys this? C1NH we can have this congenital deficiency, जिसके कारण we might have hereditary angioneurotic edema. ठीक है? This is important. So C1NH is a potent inhibitor of converting your high molecular weight kininogen to bradykinin. अगर ये मेरा inhibitor inhibit हो जाएगा या इसकी congenital deficiency होएगी, I'm going to see a buildup of bradykinin and that's going to mediate angioedema. ठीक है? This is important. All right, guys. So we जो हमारे receptors हैं for your kinin, they're of two types. We can have B1 receptor, then we can have B2 receptor. ठीक है? So let's see the effect of these kinins. What are they going to do? Mainly arteriodilation. They're going to lead to arteriodilation. That's the first thing. Inflammation में they're going to play a very important role. Nociception में they're going to play a very important role. ठीक है, सारे के सारे जो हमारे 4 classical symptoms of inflammation है, redness, local heat, swelling and pain, all of that is mediated by a bradykinin. ठीक है, they elicit pain as well. I told you this is nociceptive as well. And just remember, ACE inhibitors जैसे drugs में जहाँ पे bradykinin increase हो रहा था, they might lead to dry cough, that is brassic cough as well. ठीक है, so these are the effects of your kinins. Right. And this was telling you about, guys, we have something known as hereditary angioneurotic edema, also known as Quincke's disease, which occurs due to C1 esterase inhibitor deficiency. So this C1 esterase inhibitor deficiency, iske karan I'm going to see this activation of the classical complement pathway as well, and ultimately I'm going to see more conversion of your high molecular weight kininogen into bradykinin. Okay, all right. Now, yeah, then I have the natriuretic peptides, very important for your CHF now. So natriuretic peptides, mainly इनका नाम मतलब क्या है? Natriuresis. They're going to cause sodium loss. That's the first thing that I see over here. They're going to cause sodium loss. ठीक है? Mainly they're secreted from the heart. This is what I have to know. हमारे पास 4 टाइप के हैं. We're going to study mainly 2. That is, you have the atrial natriuretic peptide, you have the brain natriuretic peptide, we have the C-type natriuretic peptide, and we have urodilidin. All of them are natriuretic peptides. Okay? So let's see one by one. First, I have the ANP. Just by the name goes, mainly it's going to be secreted by the atrial myocytes due to stretch. Whenever the blood volume is going to increase, whenever I'm going to see an increase in the blood volume, this is going to stretch my atria. And whenever the atria stretch, then I want कि मेरे को blood volume कम करनी है. And वो कैसे कम कर सकता हूँ? Via natriuresis. Okay, so this is what happens. So this is my ANP. So this ANP is mainly released by the atrial myocyte, but इसका मतलब ये नहीं है that's not released by the ventricles. It is also released by the ventricles as well. Okay, right, guys. The next one that I have is BNP, that is brain natriuretic peptide. Again, brain natriuretic peptide is a misnomer. Brain, it was derived from porcine brain. इसका मतलब ये नहीं है that's predominantly present in हमारा brain. Mainly it is predominantly present in the ventricles. ठीक है, तो again due to stretching of the ventricles we're going to see an increase in the brain natriuretic peptide की levels as well. ठीक है, so BNP is named as it was originally identified in your porcine brain. ठीक है, right. So very important, super important slide for us because यहाँ पे हमारे पास थोड़े से drugs आने वाले हैं which is going to function via this pathway. So the first drug that I want to tell, जो सबसे easy है, that I have something known as nesiritide. So this nesiritide is a recombinant BNP. ठीक है, and this BNP mainly हमारा natriuresis कराएगा, vasodilation कराएगा, decrease in afterload कराएगा. मतलब I can use this in CHF. ठीक है, it's given intravenously, it's very expensive. So nesiritide, that's a recombinant BNP, I can use that. Just remember, guys, this natriuretic peptide, NP for short, it's going to get converted into its degradation products. Remember, via this enzyme that is known as neprilysin. Okay? Neprilysin is going to convert your natriuretic peptide into its degradation products. So this neprilysin is also known as neutral endopeptidase. So what I can do is I can inhibit this neprilysin. I'm going to call these drugs as neprilysin inhibitors. But इसके कारण I'm going to see an increase in the ANP and BNP levels. And this is good for us because mainly they're using CHF. So what is the drug that I have? The drug that I have is sacubitril. Sacubitril usually comes in a combination that is ARNI, that is angiotensin receptor blocker, plus neprilysin inhibitor. So AR and NI, ARNI. So what is the angiotensin receptor blocker that I have? Valsartan प्लस साक्यूबुट्रिल का दोनों का कॉम्बिनेशन है ये, विच इज नोन एज आर्नी, विच इज गुड फॉर योर CHF. ठीक है, सो दैट इज द फर्स्ट थिंग. एंड जस्ट रिमेंबर गाइस, ये जो न्यूरो पेप्टाइड रिसेप्टर है, न्यूरोपेप्टाइड रिसेप्टर्स जो है मेनली दे आर विच लिंक, दे आर guanyl cyclase link, so these are enzyme linked receptors, so they're going. हेलो गाइस, या सो यू टॉकिंग कि जो हमारे ANP रिसेप्टर्स जो है मेनली, या नेट्रियोटिक पेप्टाइड रिसेप्टर्स जिन्हें मैं कह सकता हूँ, दैट इज NPR, ये मेनली मेरे guanyl cyclase receptors हैं. So I have two types of receptors. Mainly, I want you to remember we have ANPA receptors and we have ANPB receptors, also known as NPR1 receptor and NPR2 receptor, and both of them are enzyme linked receptors. So ANPA receptor is mainly it has selectivity for both ANP as well as BNP, whereas ANPB is specifically for your C type of natriuretic peptide. Okay, so just remember these are guanyl cyclase link, and I have these drugs. I have nesretide, that's a recombinant BNP, or I have your sacubitril, which is a ARNI. That's it. Basically, combination में आते हैं वो with valsartan and sacubitril. Okay, so these are the drugs that I have. All right. The next जो मेरे vasoactive peptides है, actually I don't have them all. So basically we just want to remember the last that I want to discuss is substance P. Okay, so we just remember the substance P है, it belongs to a bigger family of peptides, which is known as the tachykinin family. ठीक है, उसमें मेरे different neurokinins भी आते हैं, neurokinin 1, neurokinin B, neurokinin A and B, and your substance P also come. So mainly it is a neurotransmitter and it's mainly present in the brain and the spinal cord. ठीक है, जो मेरे पास रिसेप्टर है न्यूरोकाइनिन का, आई एम गोइंग टू कॉल इट एज NK1 रिसेप्टर, न्यूरोकाइनिन 1 रिसेप्टर, जो हमारा मेन रिसेप्टर है. इट इज अ GQ लिंक्ड IP3 टैग लिंक्ड रिसेप्टर. ठीक है, and now what is it going to do and what are the drugs that you have? Basically this substance P, whenever it's going to act on the chemotrigger zone, it's going to mediate your nausea and emesis. Okay, and this substance P actually क्या है ना, it's going to get released by whenever I'm going to give chemotherapy. तो chemotherapy में जो भी मेरे cells destroy होंगे, they're going to release enormous amount of substance P, and this substance P can actually work where it can go and work on the chemotrigger zone, and that can lead to nausea and vomiting, that I see chemotherapy induced nausea and vomiting. So I can develop drugs which are going to block this receptors, which I already talked, जो हमारे neurokinin 1 receptor है. If I use some drug which is going to block that, I'm going to combat this either post-operative nausea and vomiting or your chemotherapy-induced nausea and vomiting. So let's see the drugs that I have. The main drug that I want to tell is aprepitant. So the aprepitant is the first antagonist that was approved for a chemotherapy-induced nausea and vomiting. So this is what we need to know about all of the vasoactive peptides that we have. The one more thing that I want you to remember is CGRP, mainly in case of your migraine. We won't go into the details of your migraine. Just remember the different drugs that we have for your migraine. I have mainly your erenumab. Okay, so the different drugs that I have is CGRP antagonist है मेरे पास, that is erenumab. And just remember the CGRP है, that's going to mediate your vasodilation that happens in your migraine. Okay, so we need to combat that. We need to make the cerebral जो हमारे जो blood vessels है उन्हें vasoconstriction mediate करवाना है. So we're going to inhibit this CGRP, that is calcitonin gene related peptide. ठीक है, all right. Now, the last drugs that we're going to discuss today is mainly about digoxin. ठीक है, digoxin is a cardiac glycoside. ठीक है, so this is the last drug जो हम आज discuss करेंगे. That's your cardiac glycoside, that is digoxin. We have different. We can have bufotoxin as well. Bufotoxin is also a cardiac glycoside derived from toad skin. We have digoxin, which is derived from your foxtrot. ठीक है, so let's see इनके actions क्या हैं of your digoxin. ठीक है, all right. But पहले let's just see इसका mechanism of action क्या है. Then we're going to see its action. Okay, we've already seen in nerve muscle physiology how it's going to inhibit this sodium potassium ATPase. So this is the receptor. This is the structure that I want you to remember. Do you see this obane binding site? Obane was also a cardiac glycoside. Okay, so the sodium potassium ATPase पे extracellularly there is a site. This is known as the obane binding site. And whenever digoxin binds to the obane binding site, it's going to inhibit the sodium potassium pump. Whenever this sodium potassium pump is inhibited, what was it doing was it was throwing 3 sodium outside and taking in 2 potassium inside. So whenever I'm not able to throw the sodium outside, I'm going to see an increase in buildup of your sodium. Okay, so sodium intercellular is going to increase. But problem यहाँ पे ये है that usually whenever contraction of a muscle is gone, whenever I want to mediate muscle relaxation, this calcium is often pumped outside as well via this transporter which is known as NCX, that stands for sodium calcium exchanger. So this sodium calcium exchanger ये क्या करता है? It throws out the calcium whereas it takes in the sodium. And why was it taking in the sodium? Because जो sodium potassium ATPase से जो हमने concentration gradient develop किया था for sodium, वो अब हम use कर रहे हैं. ठीक है, अभी हमने क्या किया? Because we have inhibited the sodium potassium ATPase and because there is an increase in sodium inside, increase in sodium inside भी है, increase in sodium outside भी है, there is no concentration gradient, मतलब sodium can't move inside due to this NCX channel. And what will happen? Now the calcium is going to get deposited. Now the calcium is going to accrue more. And this calcium actually ऐसा नहीं है कि calcium is going to maintain tetani. All of this calcium, extra amount of calcium that we have not thrown outside, actually this goes into the sarcoplasmic reticulum and it gets stored up. It gets loaded up. So this excess calcium जो है gets loaded up in the sarcoplasmic reticulum. और जैसे जैसे टाइम जाएगा एंड जैसे जैसे द digitalis का एक्शन टेक्स प्लेस, you're going to have more amount of calcium in the sarcoplasmic reticulum. Ultimately we have developed enough amount of calcium in the sarcoplasmic reticulum, and hence that is going to lead to the positive inotropic action of my digoxin. More amount of calcium with the more amount of contraction. Okay, so just remember guys, when we discussed about your cardiac muscles, we talked about this coupling known as electrochemical coupling. Okay, what was that? Electrochemical coupling के accordingly जो मेरे यहाँ पे डाइहाइड्रोपायरेटिन रिसेप्टर्स थे, यहाँ पे हमारे राइनोडीन रिसेप्टर टाइप 2 था. They were not mechanically linked. What was happening was whenever calcium was entering via the DHP receptors or via the L type of voltage gated calcium channels, this calcium was inducing calcium release from the sarcoplasmic reticulum via this transporter which was known as iodine receptor type 2. So I'm going to call it as calcium induced calcium release. ठीक है? So this is what is going to happen. जो भी हमने extra amount of calcium जो हमने अंदर store up कर लिया है via inhibition of the sodium potassium ATPase, via indirect inhibition of this NCX, we're going to have increase in calcium, and this increased amount of calcium is going to get stored up in your sarcoplasmic reticulum और वो further हमारा use हो जाएगा. So this is the mechanism of action of your digoxin. So let's just see इसके actions क्या हैं. It's going to have a positive inotropic action. It's going to increase the contractility of the heart. That's one. It's going to lead to increase in cardiac output, and it's going to have a decrease in the heart rate. This is important. Okay. So this decrease in the heart rate is actually due to the increase in vagal tone that is mediated by your digoxin. So जो digoxin है, it mainly stimulates the vagus, और उसके कारण I'm going to see a decrease in the heart rate. ठीक है, very important. But it has been also seen कि जो decrease in heart rate है, it is more important in CHF patients. Now see this guys. Whenever I'm going to have congestive heart failure, मतलब I'm going to have forward failure. ठीक है, मतलब मेरा heart is not going to pump well, आगे की तरफ blood is not going to go to the vital structures. उनमें से one vital structure is my vagus. ठीक है, so whatever जब भी मेरा I'm going to give this cardiac glycoside, that is digoxin, what's going to happen is जो मेरा ये positive inotropic action है, इसके कारण circulation is also going to improve. And when that circulation improves, my vagal tone is now going to increase. And whenever the circulation improves, I'm also going to see a reduction in the sympathetic overactivity. And that is the reason why I'm going to see a fall in heart rate that is seen in digoxin. What else? Very importantly is, जो RMP जो है हमारा, it's going to get reduced. When I see reduced, मतलब I'm going to see a positive decrease. मतलब -90 से it's going to become -70 millivolts. So this is the its effect on your action potential. What about next? जो हमारा then we're going to see delayed after depolarization. ठीक है, so what are these delayed after depolarization is because हमारा इतना ज़्यादा amount of calcium जो हमारा store हो रहा है inside the cardiac myocyte, उसके कारण I'm going to see these delayed after depolarization. ठीक है, मतलब whenever I'm going to see, मान लो ये मेरा अगर वो है, तो I'm going to see a delayed after depolarization that can occur due to increased amount of calcium that is building up, and that might lead to a ventricular premature contraction. ठीक है, so that is the reason why this VPCs can occur over here. Alright, just remember digoxin also decrease the AV nodal conduction. मतलब ये मैं उन conditions में नहीं दे सकता where the patient is already suffering from a heart block. ठीक है, उस केस में I can't give digoxin. ठीक है, but I can give digoxin जहाँ पे I'm going to have some kind of atrial flutter or some kind of atrial fibrillation. जहाँ पे what is happening is atria मेरे fibrillation में है, and I don't want all of these signals to travel via the AV node into the ventricles so that VT ना हो जाए. तो इस करके I can block this AV nodal conduction by giving digoxin. So just remember that. तो उसका एक use हो जाएगा. That is your rate control in case of your atrial fibrillation and atrial flutter. So that is one use of your digoxin. Okay. Just remember guys, ECG may we see a very characteristic change with digoxin. What do we see? We're going to see T-wave inversion, and we're going to see a sloping ST depression. So there is a sloping ST depression and there is a T-wave inversion, and this is what I'm going to call this as the reverse stick sign or the hockey stick sign or the Salvador Dali mustache wala sign. Okay, so this Salvador Dali mustache, or I can call it as the reverse stick or the scooped or your hockey stick sign. Okay, that's important. One more thing, interaction जो है मेरी guys, that is जो potassium जो है, it's going to reduce binding of digoxin to its obane binding site. मतलब whenever I'm going to have increased amount of calcium, increased amount of potassium, that's going to protect against your toxicity of digitalis. ठीक है, so increased amount of potassium is very protective. So whenever I'm going to have digoxin toxicity, the first thing that I'm going to say is कि potassium levels को देखना is very important. Because if the potassium levels are low, I need to increase the potassium levels so that digitalis की या digoxin की toxicity further develop ना हो. Because they are going to prevent, the potassium is going to prevent digoxin from binding to its obane binding site. ठीक है? So this is what I was telling you guys about कि हमारे पास जो ऑटोमेटिसिटी है दो टाइप की हो सकती है. वी कैन हैव अर्ली आफ्टर डिपोलराइजेशन और वी कैन हैव डिलेड आफ्टर डिपोलराइजेशन. यहाँ पे आई जस्ट वांट यू टू रिमेंबर जो डिलेड आफ्टर डिपोलराइजेशन है दैट इज मेनली ड्यू टू योर एक्यूमुलेशन ऑफ कैल्शियम. ठीक है. एंड दिस इज व्हाट इज हैपनिंग कि मेरा एक्शन पोटेंशियल हो रहा था एंड लेटर पार्ट ऑफ द एक्शन पोटेंशियल में आई एम अगेन सीइंग एन एक्शन पोटेंशियल ड्यू टू एन इंक्रीज अमाउंट ऑफ कैल्शियम. ठीक है. सो दिस इज योर responsible for your automaticity which occurs there. The next effect of digoxin is on the blood vessels. Blood vessels पे mainly it's going to mediate your vasoconstriction and that's going to lead to increase in your peripheral vascular resistance. Okay, this is very important. So मतलब it's going to increase your systolic blood pressure, it's going to decrease your diastolic blood pressure, and we see CHF patients में there's an increase in the pulse pressure. Okay, very important. And very importantly, coronary insufficiency, however, is no contraindication to its use. Okay, that's important. Kidney में due to the restoration of your circulation, it's going to function as a diuretic. ठीक है, बिकॉज हमारा जो सर्कुलेशन रिस्टोर हो जाएगा, वी आर गोइंग टू सी इंक्रीज रीनल ब्लड फ्लो एंड सब्सिक्वेंटली an increase in the GFR as well. CNS में it's going to mediate your, it's going to stimulate your chemotrygoson and that's going to be responsible for your nausea and vomiting as well. What about its pharmacokinetics? Digoxin is excreted unchanged by the kidney and that is the reason why इसका T-half can increase in renal insufficiency. Let's just see इसके adverse effects. I told you it's going to stimulate your chemotrygoson. That's why anorexia, nausea, vomiting are going to be side effects. It can lead to abdominal pain, skin rashes, diarrhea, and most importantly, I want you to remember gynecomastia are a very specific side effect of your digoxin. Digoxin can cause, it's a very potential pro-arrhythmogenic drug. It can cause any form of arrhythmia that is there. ठीक है, कोई भी form of arrhythmia it can cause it. Alright. It might even lead to an AV block. अभी हमने पढ़ा because it can delay your AV nodal conduction. The AV block can also occur. We might even develop severe bradycardia as well because हमने कहा कि it can increase your vagal tone as well. ठीक है. And now, जो भी हमारी toxicity है which is going to be developing due to digoxin, I just want you to remember we give potassium as an antidote. So potassium is given in case of your digoxin. अगर ventricular arrhythmia set in हो गया है due to digoxin toxicity, I would want you to give lidocaine. ठीक है, so lidocaine is the thing that we give here. जो हमारे 1A type of जो हमारे antiarrhythmics है, they are contraindicated over here because they're going to further increase your action potential duration and that's going to lead to further amount of AV block. ठीक है. So 1A drugs are not given. Lidocaine, however, can be given. ठीक है, right. अगर मेरा supraventricular tachycardia develop हो गया due to digoxin, we will give propranolol. And if I develop AV block or bradycardia due to digoxin, the antidote might become atropine or cardiac pacing via your mainly pacemaker. ठीक है. Or we can also use your digoxin antibody. Just remember digibyne के नाम से आती है. It only contains the Fab portion of it. It doesn't contain the FC portion, and hence it is not immunogenic to us. Okay. What are the precautions during digoxin uses? Whenever I'm going to see hypokalemia, that's going to increase your toxicity of your digoxin. That's the first thing. Thyrotoxicosis while patients are more prone to develop digitalis arrhythmia. So that's again an important drug interaction. Ventricular tachycardia में digoxin is contraindicated. That's again very important thing. Partial AV block अगर है किसी patient, when I already give digoxin, that's going to further depress the AV nodal conduction, and that partial जो है, it might become a tertiary or a complete heart block. ठीक है. Diuretics में just see जो diuretics है mainly they lead to hypokalemia, they're going to lead to kaliuresis, and that can increase the toxicity of your digoxin. An increase in calcium levels have also been seen to increase the toxicity of your digoxin. Okay. What next? This is the important thing. One of the contraindication of your digoxin is WPW syndrome. That is Wolff-Parkinson-White syndrome. And why is that is, see, Wolff-Parkinson-White syndrome में we have this extra pathway that is there, which is known as the bundle of Kent, BOK. Okay? So bundle of Kent. And we have this AV nodal conduction as well. So in some patients, in every 1/3 of your WPW patient, they have a very high risk of developing atrial fibrillation or atrial flutter. Okay? So just see. So this is what is happening. यहाँ पे we are developing micro-reentrant tachycardia occurring only in the atria. If it was occurring through this pathway, then I'm going to call it as a macro-reentrant tachycardia. Because it is only occurring in the atria itself, I'm going to call it as a micro-reentrant tachycardia. Okay? So this micro-reentrant tachycardia in these patients might lead to atrial fibrillation and atrial flutter. Done? अब in condition में क्या हो रहा है? The only thing that is preventing the conduction of all of these impulses down to the ventricle is the AV node. Because इसमें bundle of Kent क्या करता है पता है? इस केस में bundle of Kent has a shorter refractory period as compared to your AV node. So what will happen is bundle of Kent can mainly transmit more amount of impulses as compared to your AV node. But why is this not held going to break loose is because we have an intact AV node. जब तक हमारा AV node intact है, many of the impulses will go through the AV node and they will get dampened by the AV node. AV node is going to conduct some specific amount of impulses and hence the ventricles are not going to develop ventricular fibrillation. Understood? But अगर यही patient को if I'm going to give digoxin or I'm going to give any CCB, that's a calcium channel blocker, और उसने अगर AV node को block कर दिया, what's going to happen? जो मेरा बंडल ऑफ केंट है विच ऑलरेडी हैज अ शॉर्टर रिफ्रैक्टरी पीरियड, वो सारी की सारी इंपल्सेस को वेंट्रिकल्स में फेंक देगा, because it can conduct very fast as compared to your AV node. So that is the reason why this digoxin is contraindicated in two conditions. We contraindicated in case of WPW syndrome as well as hypertrophic obstructive cardiomyopathy. So these are the two contraindications of your digoxin use. And what are the uses of your digoxin? We can use it in heart failure, and we can use it in your atrial fibrillation and atrial flutter as a rate control. Okay, so this is all about your cardiac glycosides. All right. So let me just tell you some amount of drugs जो हम basically cover करेंगे in later sessions that we use it in case of your heart failure. So just remember, we can use diuretics in case of your heart failure, and mainly heart failure में it has been seen loop diuretics plays a very important role. And how do the diuretics work? Because वो blood volume को कम कर देंगे, extracellular fluid volume को कम कर देंगे, they're going to decrease your edema and they're going to decrease the preload. तो इसके कारण according to Laplace law, as you guys all know, कि Laplace law is कि मेरे जो pressure जो generate होता है, that is mainly your T divided by R, or I can say it as 2T divided by R. तो जितना मेरे रेडियस अगर इंक्रीज करेगा ऑफ माय कार्डियक चेंबर्स, उतनी आई विल डेवलप लेस अमाउंट ऑफ प्रेशर फॉर अ फिक्स्ड अमाउंट ऑफ टेंशन. तो अगर मैं प्रीलोड को कम करता हूं, आई एम गोइंग टू अकॉर्डिंग टू लैप्लेस लॉ इंक्रीज द कॉन्ट्रैक्टिलिटी ऑफ द हार्ट एंड नॉट प्रेसिपिटेट योर हार्ट फेलियर. सो दैट इज वन थिंग टू डायरेटिक्स में यूज कर सकता हूं, राइट. जस्ट रिमेंबर गाइस कि डायरेटिक्स हाउएवर कैन नॉट बी यूज इन एसिम्प्टोमेटिक डिस्फंक्शन, मतलब कार्डियक फेलियर में फर्स्ट लाइन नहीं है, ठीक है. तो जस्ट आई वांट यू टू सी दिस डायग्राम एक्चुअली. सो जो हमारे कार्डियक फेलियर है, हम एक्चुअली डिवाइड देम इनटू ए बी सी डी ग्रुप्स, ठीक है. सो जस्ट स्टडी अबाउट दैट. हम कार्डियक फेलियर ने डिस्कस कर रहे हैं, तो ए बी सी डी ग्रुप्स, so जिसमें ए स्टैंड्स फॉर एसिम्प्टोमेटिक पेशेंट्स, जहां पे रिस्क फैक्टर प्रेजेंट है बट देयर आर नो फंक्शनल चेंजेस, देयर आर नो स्ट्रक्चरल चेंजेस इन द हार्ट. बी पेशेंट्स अगेन एसिम्प्टोमेटिक पेशेंट्स हैं, जिसमें आई एम गोइंग टू सी स्ट्रक्चरल चेंजेस, जिसमें आई एम गोइंग टू सी फंक्शनल चेंजेस. सी चेंजेस, सी वाले मेरे पेशेंट्स वो हैं विच आर गोइंग टू बी सिम्प्टोमेटिक, एंड डी मेरे कौन से पेशेंट्स हैं, जो मेरे डीकॉम्पेंसेटेड पेशेंट्स हैं. So it goes like this, guys. Stage A में I'm going to give, so stage A में I'm going to give one drug which starts with A. What are they? ACE inhibitors and ARB. So just see, stage A में there's a risk factor which is present, but there are no structural and functional changes. Due to the cardioprotective action of this ACE inhibitors and ARBs, heart failure में stage A में I can give ACE inhibitors. Then I'm going to move on to the B stage. अब B stage में भी जो मैं drug introduce करूंगा, that starts with the B. I'm going to give beta blockers, especially your cardioselective beta blockers. ठीक है, हमने already पढ़ा है cardioselective beta blockers decrease the mortality in case of your heart failure. तो स्टेज बी में हमने क्या ऐड कर दिया, बीटा ब्लॉकर्स ऐड कर दिए. स्पेशली कार्बिडोलॉल इज वेरी इंपॉर्टेंट, ठीक है. उसका लिपिड एक्शन भी बहुत अच्छा है. It has antioxidant action as well. It is an alpha blocker as well. It is a beta blocker as well. Carbidollol, metoprolol, bisoprolol, हमारे ये जो कार्डियोसेलेक्टिव बीटा ब्लॉकर्स हम स्टेज बी में देते हैं. स्टेज सी में जस्ट रिमेंबर गाइस, सी के बाद डी आता है, ठीक है. तो स्टेज सी में वी गोइंग टू सी ड्रग्स विच आर गोइंग टू स्टार्ट विद डी. व्हाट आर दे? डायूरेटिक्स एंड डिजिटालिस. तो मैंने अभी क्या कहा आपको, diuretics can't be given in those patients who are asymptomatic. मतलब stage A and B में we can't give diuretics, उनका इतना एक्शन अच्छा नहीं है. So that is what I mean by that. Alright. The next drugs that we can give is vasodilators. उसमें से vasodilators कौन कौन से हैं? We can give nitrates, and we've already studied about nitrates. We can give sodium nitroprusside. हमने बात की, sodium nitroprusside is both an arteriodilator as well as a venodilator. मतलब it's going to decrease the preload as well as it's going to decrease the afterload as well. ठीक है, so that we can give in case of your decompensated heart failure. We can also use hydralazine. अब actually hydralazine का mechanism action is not known, ठीक है. But what it does is it's going to decrease the afterload by functioning as a vasodilator predominantly on the arterioles. Okay, so it decreases the pulmonary and the systemic vascular resistance, and we can use hydralazine as a potent arteriodilator. Okay, that is the thing. All right. The next drug that I have is beta antagonists. All right. So beta antagonists हमने already पढ़ा कि long-term administration of beta antagonists reduce the mortality rate in your CHF. ठीक है. But just remember, guys, beta antagonists I'm not going to use in a patient who is decompensated. I'm going to use in a patient in that heart जो कि compensate कर चुका है, वरना I'm going to worsen things. ठीक है. So beta antagonists I can use. What else? All right. The next drug that I can use, obviously I can use ACE inhibitors. हमने बहुत डिटेल में पढ़ा ACE inhibitors का and what all they can do. So I can use ACE inhibitors and I can use ARBs as well. ठीक है. Now, necitide हमने already पढ़ लिया guys कि it's a recombinant form of your brain natriuretic peptide. So ये क्या कराएगा? It's going to lead to vasodilation and it's going to lead to natriuresis, जो भी मेरा सारा extracellular fluid volume है उसे भी कम कर देगा, edema को कम करेगा. ठीक है. So all of these actions, mediation of your vasodilation by the cyclic GMP pathway, that's going to be by necitide. But necitide, how is it given? It's mainly maintained as a continuous IV infusion and it's very expensive. And what is the use? हम only use necitide in case of acute decompensated heart failure. Okay, so that is the use of your necitide. Then we have also some other drugs. So ये usually short note आया था कि what are the different types of new drugs that we use for heart failure. The necessitide is one of them. Then we have vasopressin receptor antagonist. What are they going to do? जो हमारा V2 receptor है, ठीक है, उसे एंटागनाइज करेंगे. तो V2 रिसेप्टर मेरा वो वाला टाइप ऑफ रिसेप्टर है विच वाज मीडिएटिंग योर action which was occurring where, which was occurring at the water reabsorption वाला. तो V1 receptor mediates vasoconstriction and V2 reception जो है it inserts your aquaporin 2. I think you might know aquaporin 2 का insertion जो करवाता है in case of your DCT वाले cells में, ठीक है. So this vasopressin receptor antagonist कौन कौन से हैं? I have tolvaptan and conivaptan. Conivaptan is not actually, it's actually banned. So tolvaptan we have a important drug that we use in heart failure, ठीक है. Conivaptan, right, and tolvaptan. All right. Some other drugs that I have is for you is these drugs, that is inamrinone and milrinone. Okay, inamrinone and milrinone, they're also known as enodilators. मतलब they're going to lead to positive inotropic action as well as they're going to lead to vasodilation. तो दोनों action है, इस करके हम इन्हें enodilators कहते हैं. What do they do? Is they're going to inhibit phosphodiesterase 3. उसके कारण I'm going to see an increase in cyclic KMP. Okay, so this increase in cyclic KMP can do two things. Either it can lead to vasodilation, and this cyclic KMP can also lead to increase in calcium coming inside and lead to positive inotropic action. तो दोनों चीजें करती है, vasodilation भी and positive inotropic action भी. Inamrinone and milrinone, ठीक है. Side effect इसका mainly is thrombocytopenia, which is more in case of inamrinone as compared to your milrinone. ठीक है. So these are your two drugs there. Then I have another novel drug that I can use in heart failure is your levomethasone. ठीक है. So this levomethasone का mechanism action क्या है? बहुत सारे हैं इसके. First, it does is it sensitizes the myocardium, जो troponin है present in the myocardium or present in the myocyte to calcium. So troponin C को sensitize कर देगा to calcium, so that more amount of calcium can bind to your troponin C. It also going to inhibit your phosphodiesterase 3, मतलब it's also going to function as an enodilator as well. ठीक है. इसका indication क्या है levomethasone का? Mainly इसका indication है short term treatment of your acutely decompensated severe chronic heart failure. ठीक है. So levomethasone इसका एक ही predominant use है and side effect इसका associated is your hypertension. The next drug that I have for you is ivabradine. I also call it as a bradycardiac drug because हमारा कौन से channels को block करता है? It's going to block our funny channels. And we've already seen our funny channels, how they maintain the slope for जो हमारा pre-potential वाला था, that is your SA node and AV node. मतलब they're going to decrease your heart rate without affecting what? Without affecting your contractility. ठीक है. तो अगर heart rate अगर decrease हो जाएगा, I'm going to see increased amount of diastole, I'm going to see better filling as well as जो मेरी increase in heart rate जो CHF में हो रहा था जिसके कारण cardiac work stress बढ़ रहा था, that's also going to fall. तो ivabradine we can use it, ठीक है. It's going to reduce the heart rate without affecting the myocardial contractility, ठीक है. Uses क्या है इसके? We can use it in angina. We have been using it as in chronic CHF, but chronic CHF में सिर्फ तभी whenever the patient is symptomatic. It's a case of heart rate with reduced ejection fraction. The heart rate is more than 70, and despite beta blockers, all of this is happening. So this is the specific indication of your ivabradine. Okay, and we've already seen about your sacubitril, that is Arni, that is available as a combination of your valsartan and sacubitril. Okay, so this is also we have already discussed. So this is the end of it, guys. We have already discussed all of the drugs which are given in heart failure. We've discussed about nitric oxide. We've discussed about the vasoactive peptides as well. And we've already discussed about the drugs which are acting on the renin-angiotensin-aldosterone system as well. Okay. So revise all of these drugs. I have already given you the tutorial notes as well. So please go over them as well and attempt any MCQs which are there. All of this stuff is made from your book as well. So I've tried my best to not skip any topics which are there in a book. So that was the reason why vasoactive peptides took so much amount of time. Okay. थोड़े थोड़े क्वेश्चन इधर उधर से आ जाते हैं उसमें से, तो इट्स बेटर बिकॉज ऑब्वियसली I've only discussed those vasoactive peptides which are clinically important to us. Then that means I've not discussed adrenomedalin, I've not discussed urodilatin, जो भी हमारे और vasoactive peptides मैंने नहीं discuss किए हैं. I mainly have discussed endothelin, which is important because endothelin antagonist जो है हम basically ambrisentan वगैरह we use it in case of pulmonary arterial hypertension. I've discussed substance P because we use aprepitant in case of your chemotherapy induced nausea vomiting. ठीक है. So सब drugs के कोई ना कोई uses हैं. तो इस करके हमें अगर हमें यही नहीं पता कि वो एक्चुअली वो सब्सटेंस क्या करता है, देन वी डोंट नो व्हाट ब्लॉकिंग दैट सब्सटेंस विल एक्चुअली डू. ठीक है. सो 3 chapters आर डन टुडे. टुमारो विल बी डन ओवर विद योर CVS Pharmacology. 3 chapters जो हमारे रह गए हैं वो कल कवर हो जाएंगे and that will be the end of it. Antihypertensives, anti-anginal, and your one more chapter that is left, that is antiarrhythmic. ठीक है. So these 3 chapters जो है हमारे CVS Pharmacology we are going to discuss tomorrow. I've left out the chapter that is CVS general consultation because I think CVS physiology में we already covered all of that stuff up. ठीक है. तो इस बारी आई एम नॉट मेकिंग द सेम मिस्टेक कि ANS जनरल कंसल्टेशंस आई कैन डू दैट. तो ANS हमने डिस्कस नहीं किया था, तो इस करके आई ऑलरेडी डिस्कस द जनरल कंसल्टेशंस एज वेल. ठीक है, तो आई एम गोइंग टू क्लोज दिस सेशन टुडे and I hope you like this video, and please share it with your friends as well, and please give me a thumbs up if you like this session. And if there are any queries, कोई भी अगर query वगैरह हो, you can directly reach to us on our Telegram channel as well. You can reach it to us on our Instagram channel as well. ठीक है. Alright, so I'll take my leave today. Thank you all for attending, and your support is very appreciated. Thank you so much, Pangi. Thank you for conducting this session. And this video is obviously, just like always, is going to get saved. So you can watch it at a later speed, you can watch it at even more speed as well. I'm trying my best ki almost 1.5 hours mein pura cover ho jaye topic. So I hope you love this session, and I'm going to take my leave now, and I'm going to see you tomorrow and be done with CVS Pharmacology tomorrow onwards. And then we're going to start with your CNS Pharmacology. That's going to be our job for 1 week. I'm going to try to see कि हम हफ्ते या उससे थोड़े से extra में we can finish pharmacology up. थोड़ा सा बड़ा है pharmacology, but I'm going to leave out those portions which are mainly studied in medicines, and जो भी मेरी physiology वाला portion है, I'm not going to discuss that again. ठीक है? So that's going to save us some time. So please come prepared whenever जो भी topic है. It would be highly recommended if you come and watch the physiology वाला portion and then come. When it becomes थोड़ा सा difficult to revise all of that physiology up. ठीक है? So if you watch the physiology wala video, it will save us some time so that we can discuss core pharmacology only. All right, so I'll take my leave today, guys. Thank you so much. Thank you so much for watching, and I'll see you tomorrow.